The most jarring or shocking experience has been how little we pay attention to pain in women.
I started putting IUDs now with, which is not standard care, by the way. I must say, let me just declare.
Yeah.
I put local anesthesia on the cervix because I don't understand who said the cervix doesn't have nerves.
She had an orgasm, which is the normal climax. Never had that experience before. So she knew she was dying. She knew her heart is failing. All the sweat. I was sweating profusely. My heart was beating out of my chest. Don't discuss it enough because we refuse to discuss how big an impact we have with child abuse and incest in this country, in the world, but especially so in this country. Shaming each other for having less experience than the other. Like, but you are 12.
Yeah. This is the Filling the Gap podcast, where we are working to educate you on what your mother and your doctor did not tell you. And today's guest is a very good friend of mine, Dr. Claire Kinuthia, who's very organized. She is really, let's see how we do this. I am organized in a different way. But hopefully we'll be able to tell you something and teach you something about what your doctor and your mom did not tell you. And today's topic is interesting, but not in the way that people would expect. We talk about, there are people who have podcasts about this particular topic, and it's usually very different. So I would like to welcome you.
Thank you,
Karibu sana to
Asante.
Filling the Gap. This is so cool.
So exciting.
So random.
It is. And feeling, because we've done this before, but the other way around.
Yes.
We'd ask you the questions.
Yes.
So this is very fun for me.
Fun. Good. Let's go with them. I follow the way, you know.
Yes, absolutely.
All right. So let's start a little bit. Tell me, or tell our audience who you are, what you do, maybe how we know about each other, and the things that you're working on, because you're such an excellent, fantastic human. You know me, I'm just about for bigging up people. So tell us.
I love it. I love it. So my name is Dr. Claire Kinuthia. I am a consultant obstetrician gynecologist, just like you. We know each other from school days, from the struggle days of Master of Medicine.
You look like you have a PTSD, but we may or may not discuss that today.
There's some places where I still can't walk along those corridors just yet. I'm also an executive producer and host of Circling the Rabbit Hole podcast, where I've had you as a guest several times now. So thank you also for coming to grace the platform there. Also, I guess just mainly a champion for sexual reproductive health and rights and related mental health. I'm, let's see, what else do I do? I'm a cat mom, very proud cat mom of a very chubby cat called Cheddar. And for fun, I like to travel. I like to see the country, the world just in general. And when we are not working, which is hardly ever, I'm sleeping. There's hardly anything in between.
All right. And eating.
Enjoying really good food. Yes,
all right.
good. Of course,
So that's a lot about what Claire does. We are doing the most, by the way. But
lot, true. In fact, I feel like we're overdoing. We don't know how to. I think that's part of the training in medicine. There's no off button. When you're supposed to be resting, it becomes, oh gosh, no. So then you're doing something else. So I call it active rest. That's just how I've embraced it now.
Someone told me I'm having escapism. I thought that is too dramatic. I will not accept that one. No. I'm not escaping anything.
You, first of all, we don't know which part of the universe you're at. Even half the time when we're on a phone call or a text, I'm like, uko wapi? On the globe.
I am on the globe.
You're on the globe of importance.
I am on the globe. And I'm grateful to be on the globe. So let's talk about first things first. You're an obstetrician and gynecologist. You've had some experience seeing women and women's health, but you're also a woman yourself.
Yes.
So my first question, so to speak, what has been your most shocking life event? And you can choose to answer this either from a personal perspective or from a professional perspective, what you've seen in a patient.
Maybe I'll start with, I think I'd have answered this question differently maybe 2 weeks ago, but given or maybe even last month, given the things that have happened in my life recently health-wise, experiencing healthcare from the patient's perspective has been jarring. That's the best way. Because I thought about this question as we were discussing, and I'm like, no, I think the most impactful thing that has happened to me, forget everything that happened to us in training and over the years in medicine, it's what's been happening with my health and having to be looked after in our healthcare system here in Kenya. And the most jarring or shocking experience has been how little we pay attention to pain in women.
Oh.
Yeah. And even more shocking is how little us as healthcare providers think about pain when you're providing a service to your patient. So for me, personal experience, I had a medical, so I live with fibroids and endometriosis, and being a provider who looks after women with these conditions, it's always been a bit of a, how PG do I have to keep my language?
No, this is
a bit of a mindfuck, because I know medically how to deal with these conditions, and I'm keeping on, keep abreast. There's a lot of research now than before. There's a lot we're learning from what's been happening with women's health, but the experience of real life, of day to day, and being looked after by colleagues who I love and respect so much, but still seem to be very averse to the fact that you should be looking after pain when you're looking after your patients. So having your pain dismissed, having pain being caused during procedures, and not having the option for pain relief.
Yeah.
I think that's been the most jarring for me, because a recent experience had me nearly passing out during an office procedure. And I offer pain management to my patients. So even in that space, like I assumed this is just second nature. By now in 2026, where it's standard practice that if you're going to do something that's invasive, you're going to offer pain management options. But then to find myself in a place where, despite being an advocate, despite being a provider, I couldn't even find my voice because of how much pain I was in. To then advocate, because I'm the biggest person telling everyone, make sure you advocate for yourself with your doctor. But now I'm mid-procedure, about to die, like about to pass out in pain. And that, I think, was the most shocking. So I think it's been an eye-opening experience, and I guess maybe then a pain point where maybe we should, as providers, investigate this a bit more and teach ourselves, make sure you learn, read about what options there are, provide options for your patients. I think I'm at the point where something like an IUD insertion removal procedure for me in the office, I feel like I almost don't give you the option to not have pain meds. I almost, you have high pain threshold, that's great. However, this is the options that we have available. Please pick one. Now for me, not even for you. Because I can't imagine putting someone through that kind of pain myself. Yeah.
I've been surprised by some of the patients. So I do egg collections for IVF. And very occasionally I have patients who come and tell me they don't want to go to sleep sedation because they fear the sedative bits. And I remember one of my patients, I explained, I said, well, I'll still give some local anesthesia or analgesia so that you don't feel the needle going in. And this caught them by surprise, because they've had egg collections before and that hadn't been offered. I was like, I don't want you jumping when I put my big long needle close to your blood vessels and you're doing all this stuff. And I agree with you. As healthcare professionals, if you've not been in the shoes of your patient, you may easily forget what that experience is about.
Like,
my pain threshold is very... I squeal at vaccines.
Mine is pretty high. I mean,
I am
over
not
the
good.
years I've challenged it several times, and it keeps showing up. It's like, that was nothing. But even then, I don't think it's fair. That, in fact, it shouldn't even be part of the conversation. Do you enjoy pain? Like, is that what I'm asking the patient? Or are you able to tolerate, or how much on a pain scale? Let's just believe your patient. And especially so women, because we already know we are socialized to be ashamed of our bodies. We're socialized not to speak up. We also socialized to believe the doctor is always right. So maybe step forward as the provider and fill in that gap with your patient. Literally, look what I did there.
Fill in the gap. Throw it in.
Fill in that gap for your patient so that they don't have to overstep or feel like they didn't know how to talk to you about something.
Or to ask for...
offer it to them as opposed to waiting.
There's a lady, unfortunately, who passed away, I think, in December 2025, and she was a midwife. She passed away in the States, and she was trying to advocate for herself, and I think it was preeclampsia or something like that, and it was really unfortunate that as a healthcare professional, the healthcare professionals did not listen and failed her. So that's an interesting point. That's a bit...
I know,
a lot.
It's a lot. It's been... I'm still processing. Because again,
because
lived
it makes
experience is a
you
whole
wonder
different-
whether it is because we're healthcare professionals and therefore make the assumption that if Claire comes to me, she cannot feel pain, or she knows
what to expect. Like, of course, you know, because it's something you do on a daily basis for others. But I think it just speaks a lot, because if I'm a colleague and it doesn't occur to you to offer to me, then it
what
means
happens to
this
the
is
ones
standard
who
practice. That's just all. That's the takeaway message. And I think we can do better.
I started putting IUDs now with which is not standard care, by the way. I must say, let me just declare. I put local anesthesia on the cervix because I don't understand who said the cervix doesn't have nerves. But I also put lignocaine, the gel, intrauterine into the uterus.
All right.
Excellent.
Right. Okay.
Girls are just like,
it was seamless procedure. Exactly. Yeah.
And it's
the
been
fact that also
a game
we
changer.
Have to improvise.
Improvise,
that
exactly.
There's no actual deliverable system that says this is for
this is how we
procedure.
should.
This is how we manage pain for this procedure. We kind of have to improvise. But again, we have so many options, and we've learned medicine for a reason. We know how to manipulate pain. So.
And we
Let's
can work.
Better.
And now we have pain experts as well. Some people might not know that this exists, even in the country. We have people who have specialized and subspecialized in pain management. So usually the anesthetists and anesthesiologists, those ones.
Those big ones.
And we have pain experts.
Experts, yeah.
Oh, pain.
Maybe we should create courses that they teach direct providers like obstetricians and gynecologists, so that then you as a provider feel a bit more empowered to provide options to your patient.
Because the dentists offer their own pain, pain meds. You never go to a dentist and then they just
look for someone
remove
else
your
to sort
tooth
you out,
and things like that.
Yeah.
I wonder if we should talk about then pain and our bread and butter, which is sex.
The thing that keeps us in business.
Let's talk about pain and intercourse from both a gynecologist and personally, if you've had any experiences. I'll bring in some heavy terms and we are going to describe them. So painful sexual intercourse, what is the meaning of that? Where does it come from? Tell me a little about what you think about that.
It's a complex situation where we're not believing our patients, I think, is the primary problem. Because how do I define pain? If you come in and tell me this is discomfort versus pain, it's like you're almost trying to force me to minimize my experience so that you're a bit more comfortable, just because you don't know how to go about it. But we do recognize that painful sex is something that exists, and there are so many different causes. It can be physical. Sometimes it's associated also with a bit of psychosomatic, which just means a psychological traumatic event that then causes you to be tensed up and causes a lot of pain or fear. Because I think with that we minimize is how we moralize sex and the sexual experience. You've been brought up as a girl to believe that you're supposed to be a virgin, you're supposed to stay pure, you're supposed to wait till marriage. Then you get married and then we leave you like that. So now why do you imagine that for her the experience of you should not allow anyone to touch you to suddenly transform to, okay, here's a partner, go ahead. Do you think she knows what to do? We barely have sex education. And so it's not surprising that then a lot of women will come to see their gynecologist with a very traumatic experience or very traumatic history around their sexual experiences. And I think it's unfair, but it's also understandable because then you as the gynecologist that they're seeing become the first time they teach. You're the person who's teaching them the first things to learn about their body. You've been shamed about touching yourself or looking at yourself. Masturbation is a sin, right? So then if I don't know what works or how things work or how things are supposed to look, how is a partner supposed to know? And so then even just being ready for sex physiologically, feeling arousal and all the components of arousal will be, of course, traumatic. It will be difficult. You don't understand what you need to do, so you don't even understand how to direct a partner or the assumption that your partner knows. Because
this
you
is
were
a
not
big
taught.
one. So
you assume, okay,
he must be a guy. Someone taught
somebody
him
else must
somewhere.
have taught. See, now you told me to get married, so the husband must be the one who brings in this skill set. But again, you also didn't teach the boy child anything about their bodies versus, or
what to do with a female.
Yeah.
That's a whole other
Yeah.
conversation.
The sex ed, I can talk about our times, and I don't think it's changed much.
Yeah.
It used to be around just the menstrual cycle, and even then very superficially, and it was done separately. The boys were taken aside to be talked about their things, and the girls aside. And I'm like, but everybody, it's relevant to everyone.
To bring them together.
Exactly.
I had a couple when I was very young as a doctor who went for their honeymoon for a month and then came back, and they had not touched each other like physically, like even for a hug, because they could not even figure out
like,
what are we supposed to be doing.
Yeah.
And that was really, I found that very
but it's
also because I'm a doctor and I'm a gynecologist, I make assumptions that
that's
you must know what is standard procedure,
school, right? You were taught in med school, so you assume. But if you think about before pre-med school, what did you know?
I didn't.
In fact, pre-med school, we knew the uterus sits with the
with the fallopian tubes
flying off into
we're going
the
to
sky.
attach that diagram.
And then remember the first time you see the pelvis
I was like, wow,
wait,
the ovaries are behind. They are behind.
The ovaries are behind.
The
pelvis
tubes are
is this
behind.
big. There's no space to do like this. The gut is everywhere.
Oh yeah,
it's all over. It's intermingled
yeah.
with everything. The bladder is right there. The rectum is right there. It's not what you're just used to seeing this organ that sits separately.
Yeah.
So even understanding that this is probably their knowledge base, which is biology, the classes, and the images have remained the same. They are the same ones we have in our medical textbooks for some strange reason.
They're still the same.
Yeah.
So every time I have to talk to my patients, I say first things first is they don't sit the way they are. Because, for example, when patients come with stuff like endometriosis, for those who are watching, endometriosis is when there are some cells that look like the inner bit of the uterus, which gets your period coming. They can go to the pelvis. And if they're like on the ovaries, which sit behind the uterus, you can have pain even during sexual intercourse in your bum. Yeah. Which is very discombobulating for a lot of people. And period pain as well. Yeah. So much to teach.
There's so much. And I think we could make our lives so much easier if we just accepted that we should include this from a very early age.
From very early
because
on.
we do have sex education. We call it age-appropriate comprehensive sex education. And that's what we should be advocating to have so that we don't have... I have so many... I'm sure even you have so many experiences. I'll give an example where I had a patient come in her 50s and she had been referred by a physician because she had gone there as an emergency patient because she was sure she was having a heart attack. So what had happened, when you take a fun history, she had recently acquired a younger partner. I'm trying to keep this so PG. A younger partner, and her younger partner had become exploratory. It was helping her explore herself and learn about her body. And she had an orgasm, which is the normal climax. Never had that experience before. So she knew she was dying. She knew her heart is failing. All the sweat. I was sweating profusely. My heart was beating out of my chest. I had sensations I wasn't understanding. She went to a cardiologist. Oh my God, I'm dying. So the cardiologist takes the history. They do the full exam and they're like, no, there's nothing wrong, but I think you should see a gynae. So then was referred to me. So I listened to the history and I'm like, it sounds
how
like
do
you
you
had
start?
An orgasm. And what's that? What is that? Okay. So now I have to go back to the very basics.
Yeah.
But you would think at a more mature age, having that she'd been previously married. Now this is a new partner because of change of situation personally. But then it's not that it's her first partner. She'd been married for a very long time, has grown kids. Like there's a whole life story there. But this is the first time you're experiencing this. And then it's coming as a panic. Oh my gosh, what's going on with my body, as opposed to I'm okay and this should be enjoyable. And so we had a lot of unlearning and relearning to do even in that session, and bringing in sex therapists and the likes. So it becomes a team approach. But again, is it fair that you've lived your whole life
without knowing,
without even experiencing? I feel like,
and that can be a medical condition. It's called anosmia. Anorgasmia.
Yeah.
And I used to have the figure in my head because I used to find it very fascinating. I'm going to look for that figure, but there are actually people who don't go their whole lifetime without experiencing that.
Yeah. So we should be doing better.
Yeah.
I feel.
It feels like there's so much
left out. It ends up on us, the gynecologists. But that being said, I do appreciate that there are a lot more patients that I have, the female patients who will bring their daughters in, so that we start having those conversations very early with a professional, so that then it's probably geared towards just helping them understand their bodies better, safe sex when they're ready, contraception when they're ready, so that it shouldn't be a gray area. It's not something she should be fumbling with later on in life
when it happens, and not knowing where to start.
Exactly.
And then Googling.
Yeah. And then also the women who bring their partners in for these conversations. I think
very
we are
important.
really, there's been a lot of positive change on the patient side. They're more progressive, they're more curious, they're coming in to have conversations. I'll even have male patients or friends come in with a partner so that we can have this conversation together
and understand.
So,
I'm going to add here chronic pelvic pain, which is the bane of the gynecologist's existence. 15 to 20% of women struggle with this. This is nearly 1 in 3 or 4 women who will have pain consistently outside of gynecologic pain, which is just around the period time. You can have pain that is outside of that time, and there are women who really struggle for various reasons, just having random pain in their pelvises. Women wait up to 65% times longer than men to get a diagnosis for their pain. And I find that very shocking.
Again, it's not, for me, I'm not even shocked because, again,
I feel like the figures are so big.
They're big, and they're big for a reason.
Such big figures,
because number one, you've shamed me about my body.
Yeah.
So when something goes wrong, I don't lead with, okay, something is wrong with my body. I go with, what did I do? What did I do to cause this? Or what happened? Have I washed myself strange? Or maybe I've just started having sex when it was painful. Maybe it's because I'm having sex, I'm being punished. I've been told it's a punishment. It's a sin. I'm being punished with pain. So first of all, I'm leading with shame. Even if it's an infection that's expected, that's something that's easy to manage, it's terrifying and I don't know who to talk to, or I don't even want to talk about it. So then I'll sweep it under the rug. So there are lots of women who you'll come and see later, much later than when they should have come in, because they didn't want to talk about it, or you want to kind of like, itaisha, itapita too, or I'll take Panadol until the day it stops, you know. So first, you've shamed us about our bodies. Number two, who do I talk to? Who is my safe space?
And I feel like they also don't want to come to the gynecologist because they don't feel like it may be a gynecologic problem.
But also the thing that women say a lot is, I don't want to be told I have a problem. I don't want to acknowledge or be told that there's something wrong with me, or there's a diagnosis, and I'm scared to hear that. So then of course, then you're living with this pain for longer than you should be. And yet it could easily be something that was like a yeast infection can cause pain during sex. It's so easily
so easy to treat.
And we'd move on very quickly, but you'll still sit with it, and now we are even having to treat you for so much longer because it's become a chronic infection. So simple things like that.
So audience, pain in the pelvis and in that region, please don't ignore it. Please don't sit with it.
Pain is not normal.
And it's not normal.
Yeah,
I think this is the statement. Pain is not normal. I always say, like, Jesus came and he suffered and died. Why am I suffering?
True. True.
I've used that so many times.
You should refuse to suffer.
I refuse to suffer. So from your experience, or from what you would know, is sex a brain thing or a physical thing for women? Every time I talk about it.
That's such an interesting question.
People go like, you know, the guys will just be like up and running, and then women have to be like a whole process, and the guys don't understand this, the preparation. Again,
it's really
no one
just
teaches
on
them.
and off.
They just think for them.
The best way I explain it, even when I'm talking to patients, is men are like a light switch, women are more like an oven. That's the easiest way to understand the mechanics. And so if you understand that, men will tend to, not that there are no women who are visual, but men tend to be more visually driven. So they'll pretty much just see skin. And there are men in the room, and I'm trying not to make eye contact with them, but
they're also trying not to make eye contact.
They know what I'm talking about, right? So men tend to be, it's more a visual thing. It's more, I just need to think the thought, especially if everything is functioning okay without any other medical issues, we're good to go. Women, it takes a lot more than that, because again, remember, we carry a lot of things in our minds. So you may be a mom, you have children, you have your life, your career woman, you have work stuff, you have your home life, you're constantly managing. There's no place, I think, that a woman is not managing people, managing things on a daily basis. So your mind is all over the place. So if you're just thinking about, I'll see you naked and I'm like, friend, I'm probably not even in the room with you mentally. Because there are so many layers. I'm like, okay, cool, I can see, but my brain is still thinking, oh my gosh, did I pack the car? When do I need to pick up the cuckoo, the eggs for the kids? Do I have play groups? So you need to understand that women it starts mental, it starts way before physically coming together. So you need to understand that foreplay, which is something other people seem to have demonized as well, is something that's really important. And it's not necessarily just in the room when you're together. It starts from, how are we talking to each other? What's the mood? Have we been talking to each other this last month? Tuliko sana Monday, and we haven't talked since that time. So, and then you're expecting, I'll just come home and ready to go. It doesn't work like that. So are you in good terms? Are you supporting me? Are you helping me feel supported as my partner? Are you participating in all these things that I have to carry? Because the mental load for women is a lot more. And again, it's not even a generalization. This is science. So people will come back and fight me. Oh, no, men have a lot to think about. Great, wonderful. Like I said, if everything is functioning, that can be put aside.
Yeah.
We have sex and then we keep it moving. But for women, it takes a bit more energy, time, effort, feeling appreciated, going on nice dates, give her a reason to get dressed up, things like that. They feel like small things, but it goes a long way. And so the act of sex will have started way before coming together physically. And by the time you're coming together physically, then the arousal process, because again, for women, physiologically is also much more complicated. Whereas men, it's an erection and we're ready to go. For women, there's a lot more. First of all, just
goes into it.
Yeah, there's a lot of I'm even trying to think, where do I start? Okay, there's wetness, lubrication. So that's excitement will come with some lubrication. There's lengthening of the vagina, and that's again a physiological thing that happens to make sex even possible. Then there's the pelvic pressure, relaxation, organs.
The
again,
muscles.
if you're exactly where we're coming from, painful sex, because there's so many factors that will lead to pain. And mental relaxation goes a long way as well to translate into physical relaxation. Whether she's feeling safe, whether she's feeling comfortable, is the temperature right? Where are we? Yeah. So again, so many things. Does this room smell nice? Are the sheets clean? That's where her head is. Do I look nice in this angle? Can we reduce the lights a bit? There's so many things going on in your head, right? So you can't simply say that it's straightforward or not complicated. Just accept for what it is, and then take time to understand your partner. Allow for yourself to understand yourself as a woman, so that you can help your partner understand you, and it makes for better sex in general.
I was laughing earlier because the thought in my head came, I do fertility, I do fertility work. And I've had couples who come to fight in the office because in this trying to conceive business, the guys are then like, okay, let's
this
get
is our
down
project.
on it. But the one lady was like, the room is cold. I'm thinking about how cold it is and how I'm going to have to remove my clothes. How am I going to do this? And it's strange that I've had then to learn some of these things as well, because it's not taught in med school. It's not something that our doctors would have sort of taught us. I can assure you my mother did not teach me about cold rooms and the impact
that it will have. Because again, maybe it didn't even... Because
it
didn't occur because again, which place is cold for us here? You live in strange territories. Us, we have generally fair temperatures,
fair weather.
But again, comfort, safety, being open, being able to have a conversation, those are the factors that will come into play for women more than for men. Substances and alcohol also have a big impact on arousal, because in as much as it might reduce inhibition, also questionable consent issues come to play. It will also reduce the body's response, the physiological ability to get
sensation.
Aroused. Exactly. If we're using, and which we should be using, protection, it's also very drying. So then have we factored that in? Do we have lubricants that can assist with that? Or am I just assuming that I'm ready to go, so also you should be ready to go? Yeah.
For the audience, childhood trauma of any kind causes or is a risk factor for having gynecologic and sexual pain up to 2 to 3 times more. And you're an advocate of mental health and mental health well-being. I don't think that's also discussed.
We don't discuss it enough because we refuse to discuss how big an impact we have with child abuse and incest in this country, in the world, but especially so in this country. In our context, because it's one of those things you want to sweep under the rug, and we tend to downplay perpetrators. You want to say, oh, Uncle Nani is coming, so make sure you dress like this and don't sit next to him. But now you're managing her. Why are you allowing him in the space? Why aren't you guys putting any accountability on the perpetrators? So there are a lot of girls and women who will have gone through atrocities growing up. And of course, it's going to have an impact. And a lot of gynae first visits tend to be around what happened to them during their childhood.
And sometimes they don't even know. They haven't conceptualized in their mind that was abuse then. But they now have a partner. Or they were ashamed
about it. You told your mom, because there's a lot who will come in and say, I told mom, but she made it about me. What did I do to cause him to be,
to be like that?
So there's a lot.
It's a lot of heavy. It's very heavy. It gets heavy. This podcast is getting heavier and heavier.
But again, it's things that we should bring to light because it's a lot of times it's not that you're struggling out of nowhere. You're not coming. This is not coming from a blank space or a vacuum. There's literally probably things we can find out, and dealing with them. Because again, multidisciplinary approach. We should have therapists on board, maybe psychiatrists sometimes, because some people do need medication. We work with physicians. We work as teams. Create a team around your patient so that she feels supported and she's able to recover, because it's not a death sentence. It's not lifelong. We can't say that you're now sentenced to suffering because you went through something that was out of your control in childhood or even in school, because again, a lot happens in boarding schools that we also don't talk about, and you assume your children are safe when you send them to school, and that's not necessarily true. So addressing these things head on, I think, would have better results. But even then, if they've happened, it's not that it's the end of the world. Let's manage. We also have FGM in some communities. Right? And that's another cause for a lot of pain during sex because of mutilation of the genitalia as well. So how do you support such girls? Now we have a lot of options in terms of reconstruction or at least release of contractures or
fibrosis, healing.
I'm trying to find the English. Scar tissue.
Scar tissue.
Remember the audience. No jargon. So a lot of procedures to help with scar tissue so that there's less pain. Even if you're not able to restore where you should be or full restoration, at least you're functional. There's a lot.
It feels like we've seen a lot in this mother-doctor. So we learned a lot. It feels like we've learned our stuff by virtue of going to med school and being doctors rather than from, from homes or family. And that makes me really think and be intentional about this particular podcast because if the moms are not having the information or not translating that, and the doctors are also not translating that information, there's a whole population that has no idea.
Or even worse, because we have to, again, another elephant in the room we refuse to talk about, the internet now. And the access your children have to the internet. You think you know. You think you understand how social media works until you sit down with a young person. Because even me, I think I know because I'm working in that space a lot. There are sections of what feels like an innocent app that your children are learning the wildest things from. And so not teaching them, burying your head in the sand is no longer an option because they are learning from social media, sources. From crazy websites. I mean, it's crazy podcasts as well. They're also learning from porn. And that's a big thing, a big problem we're having, where we have a lot of porn addiction, both in young men and women. And it's impacting how they interact with each other. So again, we are no longer in a place where society-wise you can say, oh, let's not talk about it. There's no need to bring these things up. Oh, no, my daughter doesn't do that. My son doesn't do that. Listen.
And I mean, when I was in fourth year med school, which is a long time ago, audience, guys, I know I look like I'm young, but I'm old. I remember going to a primary school in one of the biggest slums in Nairobi and getting very shocked by what this was class 6 to standard 8. I think there must have been 11 to 13-year-olds. And the kind of questions that they were asking me then. And I went to the principal and I took this to our community health department because we used to do community health and say there's a crisis and you guys are not seeing that problem. And I'd sat on the floor. I remember sitting on the floor in jeans and a t-shirt to fit the environment and the things were so shocking. So I cannot even now imagine where they have phones in their bedrooms by themselves.
Putting it on the internet.
And it's
because
on the
I
internet.
get sent those videos all the time. Like, should children be talking like this? Shouldn't someone intervene? Because then they're children. I'll call them children because they are children, they're underage, but they're talking about sexual experiences and their prowess and the things they've been exposed to and shaming each other for having less experience than the other. And I'm like, but you are 12.
Please hear
you're
that.
using the
that
word
is 12.
Experience at 12.
Experience.
What do you mean? What do you mean?
They should be playing those funny games we used to play.
That we used to play. It should be outside. But no,
yeah.
outside is not safe. So now parents will coddle you, but then they don't understand that you have access to the internet and you have access to friends. Even if I deny you a device, your friends have access.
Will have the access, so and they will still talk to you.
Yeah. And I'm not talking... Because now in your minds you might be visualizing middle-class bougie kids who have access to technology. No. I'm talking about the videos I've been sent is children who live in literally the slums, who are standing as a group talking about their experiences. And a girl will come up and say, yeah, in fact, when this one and this one did what they did to me, this is what I felt about it. And that was my face the whole time. I'm like, what am I watching? And how is this on the internet? And also, where are the parents? What's going on?
The parents are busy doing things, whatever it is, hard. And not being vigilant. And for our audience, we do have now girls who are getting their periods as early as 9 years old, 9 to 12.
I've dealt with,
I had an 8-year-old
pregnant
actually.
9-year-old from assault, and it's such a traumatic thing to think about.
So parents, or even if you're not a parent, share this with your parent, your mother, who didn't tell you some of these things, to just get them out of that headspace of my child and how I've raised my child. It's like they're pure and no one has adulterated them, because the world is a crazy place. Yeah. Maybe we get off the heaviness, the dark and heavy of pain, make it a little light, but we'll still not veer off too much from intercourse. Normal intercourse, when people are trying to conceive, when I proclaim what it is, everyone gets a bit like, really? 2 to 3 times a week, every week for 52 weeks. Nearly 80 to 90% of couples will conceive within that time using that method. Yeah. Up to about 30% will conceive in the first month or so. 11% chance that you conceive in a month for trying to conceive. So if we bring pain and all the things about intercourse, then you can see there's a lot of couples who will then try to conceive and not conceive, either because they're skipping the times. And I came across an interesting paper, 2025, in the Reproductive Medicine Journal, that said 97,000 women were interviewed in the UK, and only 41% of them could explain roughly when they think they ovulate.
Right. Not surprising. What we've said, lack of education. Yeah.
So there's a lot of gaps to fill.
A lot. And again, if you don't understand the basics, you miss out on everything, including the one thing we really put a lot of emphasis on, which is fertility and having children. And we are very big on it culturally, but we have barely any support to help couples conceive, to even understand when ovulation happens or when am I fertile. Because I'll have couples come in and say, we've been trying for 6 months and we're not succeeding. And then you'd start asking a bit more history. First of all, we don't even live together. You work in Nairobi, I work in Bomet. And when we are trying actively, it's maybe once a month, if even that. Yeah. So 6 months in, we are both frustrated. But I'm like, you've not tried. You're not trying. In fact, by textbook, you've not even started trying for a baby. And they'll leave there very frustrated because I've refused to give them medicine treatment. Yeah. But I'm like, just have more sex. It's that simple. So again, just understanding your menstrual cycle, you need to understand. Now, again, beauty of technology, we have apps. You don't even have to say, you remember those beads? Used to give patients beads that look like a rosary thingy.
Oh, the other one for, what was that thing on
it's like, it used to be a game.
We have to find whatever it is called. It looks like a game, and you have to do the beads and move the beads.
To just count your days. Yeah. We've moved on from there. Yeah. So we have lots of apps that will monitor your cycle. Yeah. It's mainly to understand or predict when your period is coming. That's what a lot of women will use it for. Because when you come into a gynae, the first question will ask you, when was your last
menstrual period?
And we need to know. It's not we are being invasive. We're just reproductive health centers around the menstrual cycle. So we have apps now. And a lot of the apps will, if you're tracking your period, when it starts and when it ends, it will also now start predicting ovulation and your fertility window. So it's not just giving you a day, it's showing you the period when you're most likely to conceive. Yeah. So if you just used that as a tool,
as a starter,
you don't even need us. You don't need us until much later. Yeah. Yeah.
I mean, we could talk forever. We've done so many podcasts with you and we never finish. This is so easy. This is very true. But maybe a word on exercise, because we both train. We're
we are both
very
active
we
in the gym.
enjoy.
We seem
the
to enjoy
gym.
suffering.
Yeah.
Chuma kwa gym.
So we both like going to the gym for different reasons. But what would be your thoughts or words of wisdom to someone who's thinking, oh, exercise, what is for older people, other people, not just me?
Yeah.
You've experienced chronic pain.
Yeah.
What does exercise do?
Exercise goes a long way to help with management of chronic pain. There's the direct effect because endorphins just make you feel fabulous and you feel happy and
endorphins
energized.
are chemicals.
Chemicals. Your brain starts swimming in happy juice.
Happy
That's
juice.
what I call it, happy juice. So after an exercise program, especially where you've challenged yourself, you're going to feel amazing because you have a bit of adrenaline in the system, you have your endorphins, so your brain is just happy. In healthy stimulation, healthy stimulants, you don't need to seek substances for these changes. So there's that direct impact, and it makes perception of pain internally for your brain a bit different. So you're able to tolerate it a bit more, and pain meds are also found to be a bit more effective as well. Then there's the fitness aspect, because being fit, being healthy, blood flow is optimized, heart health is optimized, muscle strength, pelvic floor strength as well. All that will contribute to better sexual experiences, better climaxes. So it does overall benefit you. We also talk around menopause. We've talked about perimenopause and menopause and the changes that come. Women going through that transition lose a lot of bone, and osteoporosis, which is bone thinning, becomes a real issue. We found there's a direct impact or positive impact when you're lifting weights, when you're building muscle, because it keeps those bones healthy. So even then, with pelvic floor exercises, because there's also the changes that happen from loss of estrogen with supporting the muscles of the pelvic floor. So we have uterine prolapse, so the uterus starts to drop. Which can lead to incontinence. You're peeing, you laugh and you pee. A lot of women think that's normal.
And coughing and peeing.
You cough, you pee.
Yeah, they think
you turn sideways, you pee. And then some will qualify from, no, it's not a big issue. It's just a little.
It's just a little.
A few drops. But
I put a pad.
Yeah, and then you go to tell me, but I have to wear a liner every day. And I'm like, but that's a problem.
That's a problem.
That's not normal. So all those things can be improved significantly with exercise, and more so strength training. Women are afraid to lift weights because
they feel like we'll
bulk. Turn into boys or look like
but
men.
we've been lifting, we don't look like boys.
I'd like to think I don't look like
even me, I hope I don't. maybe we do.
Maybe we do, and
are in denial.
To tell Lisa production.
Yes.
Kama wanatuona hivyo.
They might be saying,
they might be looking at us and going, ooh, those traps. That bicep is really
it's too much.
It's too much for a girl. But I don't think so, because again, the female body has its own composition, and there's only so much proportional fat to muscle distribution. So unless you're really, really, I mean, we do see those women, but then they live in the gym. They're training to look like that.
And some of them are using other things to enhance.
Again, substance abuse stories. So it's not that you're going to bulk up or you're going to start looking beefy and look like a man. That's not the aim. It's that you're going to be a lot healthier. Blood flow stops being an issue. Independence. I tell women this a lot, because as we're aging, you're more susceptible to fractures, you're more susceptible to
falls,
joint inflammation, falls, just dementia. And all this has been found that those women who are actively training, not just walking or swimming or just cardio workouts, those who are training actively, lifting weights and building muscle, have a longer period of time where they're living, because we live longer anyways, where they're not suffering. They're independent. You can actually get up out of your bed, out of your chair, and move around your house comfortably, as opposed to having to depend on someone to look after you. So it maintains that independence for much longer. You've seen the women in their 70s and 80s now who go to the gym, and they're
seeing the future
looking so happy,
bright,
and they're so independent. I mean, the day I do a pull-up, Aki, you guys
at least I do pull-ups. I use assisted pull-ups with my band.
Yeah, I can do assisted. I'm just like, no, but that's not.
No, we must.
You know how
maybe we should make it our aim by the end of this year.
By the end of this year.
We just need 10. We don't need many.
Unassisted. I'm just waiting for one.
Yeah.
That one, I'll become insufferable.
Be 10. Be walking around and
going,
I do pull-ups.
I do pull-ups, guys. Nothing can faze me now.
I'm a pull-up girl. So... I mean, at the risk of continuing this forever, the previous guest will normally leave something for the future guest. You're the future guest now. And then you will have another future guest. Right. The previous guest left two things. Ignorance is not bliss. And investing in a lot of information to be able to just live life generally. If you're investing in information about how to cook or whatever it is, it just helps.
Yeah.
What are your thoughts on that? And then you give us the next piece for the next guest.
It's literally what we've said this whole episode. Information is power. And once you're empowered, you are so much more capable of making good decisions for yourself. It's not about controlling how people live their lives. It's not about, even when we're teaching you about sex, it's not about changing your morality and your belief system around sex. I'm not asking you to become promiscuous because that seems to be the biggest fear, that the more that we educate our children, the more promiscuous. I find it's actually the other
opposite
way around.
yeah,
that the more
I find they're
information
even
they have,
they're better defending
yes,
for themselves in those
they actually
situations
now
because they have
step
the
back and go like,
information.
I don't actually want this for myself. So you'll find that they're making more informed decisions, and those decisions are the ones you're hoping they will make. So at the end of the day, information truly is power, and wherever you can, whenever you can, whatever department, because us, we're very good with medicine, and then we're very bad at everything else.
Yeah.
So I've been proactively,
We're doing better.
We're much better. I've been proactively taking the time to learn something new pretty much every week.
Yeah.
I can't do every day because I have so much medicine to be practicing, but every week challenge myself, even if it's just experiment in the kitchen, experiment with a new recipe. I'm cooking more often, regularly.
Yeah,
now.
well done you. Well
Look
done.
at me.
Well done.
My kitchen is no
I
longer
made
just
prawns.
a space. Ooh, yum.
Yeah. So now the next thing is octopus. That's where I'm
Ooh,
headed.
okay,
I'm really
okay.
leveling it up. So
Yeah. So again, skills like that. I'm coloring a lot, just as my
I saw you painting.
I'm painting so much more, just as my downtime build the creative side of my brain as well. So it's not just physical health, you're also trying to focus on mental health as well, in ways that are you don't have to spend money. That's the other thing you have to learn about looking after yourself. You can do it in the comfort of your home. You can find easier, cheaper, affordable resources and just make it a fun thing. Knitting, for example, helps us with concentration, dexterity. I've been knitting on the side forever, and I find that it helps with surgical skills
I
as well.
I should go back to that. My surgical skills.
Yeah.
No, I'm impatient now.
You're impatient.
I'm impatient.
No, imagine I'm learning patience. Oh, I've become a plant mom. Sorry.
Welcome.
And if there's something
It
that's taught
is
me
so
patience.
good. Oh yes. And bringing back a plant to life.
What? Because for the longest time, my succulents were dying. Kumbe, it's me who's overwatering.
Overwatering them and they
alone,
become
they'd
fat.
come back.
And then
I'd
the leaves
discard
fall.
them.
Talk to me.
I've come a long way now.
I'm working in the Ministry of Forestry in my house.
In
We
your
have
house?
forest. I now have a tree, a big
Oh,
tree. So
wow.
yes, I like
Yeah,
that. And
'cause
even
that's-
gardening, stuff like that is very
stuff like
just
that for someone
touching
like me who
stuff
doesn't
and
have patience as part of my inbuilt
curriculum.
DNA.
Yeah.
It's literally teaching me so much, and small things like that you might not think are a thing. As much as we are taught to socialize, sometimes socialization is with self. Sometimes it's
knowing yourself.
introversion, understanding yourself, becoming a bit more self-aware, educating yourself from the right sources, because we have a lot of misinformation online. And that, I think, is very empowering. And you'll be finding yourself able to make decisions from an informed perspective, even when you come in to see your doctor. It's not that I'll bully you into something you're not comfortable doing. So I agree fully with your previous guest.
Okay. So
I
what
endorse
is
that
your
message. Mine will be
yours
a
for the
quote.
best? Oh, quote. Guys, we are getting
Mine will be a
quotes.
quote.
Quotes. You know I love quotes. I'm such a sucker.
Because I think I read it and it really, for where I am in my life, I think it was a moment of going, so I hope it'll have the same effect on your next guest.
All right.
So this is what it says. The most powerful magnet on earth is loving your own energy. The way you see yourself shapes your frequency. Embrace self-love, trust in your talents and how you express them, and appreciate the reflection in the mirror. May your energy elevate the frequency of the entire planet.
Oh.
Let's go deep.
I'm privy to who the next guest is, and I think she'd resonate with that.
Good.
But I preempt.
You're preempting.
Thank you so much.
Oh, thank you
This
for
has
having
been such
me.
a pleasure.
This has been, as usual,
I
with
know.
us just sitting, having a cup of coffee.
I think we should just have our own podcast all the time
All the
by
time.
ourselves.
Yeah.
To
We
be
just talk to
captured. Yeah,
ourselves.
we just talk to
I
ourselves.
agree. I really agree.
Thank you so much for gracing us
Thank
for
you.
filling a lot of gaps, especially in a conversation that has been really neglected and people are sort of touching around it without knowing how to talk directly. And we mentioned that it was going to be talking about a topic. The topic has turned out to be sex and intercourse in a way that other people don't talk about.
We're not
It's
here to make it
very,
salacious.
we're not,
It's a normal, healthy function of
Yes.
human beings.
Yes, important.
Yeah.
So thank you.
Thank you for having me.
This has been Filling the Gap. We have been trying to talk about what your mama and your doctor, or the other way around, what your doctor and your mama did not tell you. And we hope that has been useful. And if you found this useful, please like, subscribe, share, your mother, your sister, your niece, your friend, everyone, including men, actually. And we will see you in the next episode. Asante sana.